Good morning, everyone, and thank you for joining us for another APSARD Insight webinar. My name's Tracy, and I'm one of the nurse educators here at Insight. Before we begin, I'd like to acknowledge the traditional owners and custodians of the land in which we're presenting today. So for us here, it's the Yagara and Turrbal people in Brisbane. I'd also like to pay my respect to elders past, present and emerging, and I'd like to extend that respect to any Aboriginal or Torres Strait Islander peoples who might be joining us today. So as I'm sure you're all aware now from our program, we have Dr. Shalini Arunogiri joining us today for a very interesting discussion on social connection, pain and opioid use, and to present findings from a pilot program that uses a social prescribing approach to enhance social connection in older adults who are living with chronic pain. Shalini is an addiction psychiatrist and senior researcher, and also the Deputy Clinical Director at Turning Point in Victoria, a very busy lady indeed. Just before I hand over to Shalini, a little bit of housekeeping. I think most people are quite comfortable with Zoom by now, but if you have any issues or concerns, let us know by using the chat. And we'll attempt to assist you there. Likewise, if you have any questions, please pop them in the chat and we'll get to them at the end of the presentation. That's it for me, and over to you now, Shalini.
Thanks so much, Tracy, and thank you to everyone at Insight for having me along to talk about this project. Really great to join you this morning from Victoria, where we're in lockdown, but presumably most of you are in Queensland, and so I'll try to make this as relevant as possible to anyone who's joining us from there as well. So as Tracy mentioned, I work at Turning Point, which is based in Melbourne, and we're a statewide centre for substance use disorder and gambling treatment. And I also work across research at Monash University and at Turning Point. Today, I'm joining you to talk a little bit about something left field, I suppose, for us here at Turning Point. This is a project focusing on social prescribing. So a project that looks at management of isolation and loneliness and connection in older adults who are presenting with opioid use and pain. So just to introduce our project team, we had a number of people work with us in this project and take leadership across a range of parts of the project, and so really wanted to acknowledge their work, including our project lead, research fellow and health psychologist Angela Simpson, and psychologist Sally Brown, who were pivotal in driving this project across the last year. The project is called OP-ALMA and looks at opioid use and pain, addressing loneliness in mature adults. And really wanted to acknowledge the funding support of Gandel Philanthropy, who contributed to making this project a possibility. So by way of background, to talk a little bit about why we're talking about this today, I'm an addiction psychiatrist, and all of our teams here at Turning Point work with core business being addiction treatment. And we run an opioid use and chronic pain clinic as well. So the statewide clinic for opioid use and chronic pain offers assessments for people across Victoria who might be presenting with a history of chronic pain disorder, who also are dependent on their opioid analgesics. And I think for anyone joining us today, suffice to say that this is not a new problem, it's a growing problem, I think. And for older adults, there's a reasonably high prevalence of not only chronic pain, but dependence on opioid analgesics in that group. So I've presented some data here from the AIHW, which is national and released in 2020, that highlights the prevalence of chronic pain disorders across the population, and really a preponderance clearly in older adults in particular. And that people who live with chronic pain are 5 times as likely as those without pain to have limitations in their daily activities. This clearly also impacts on not just mobility in general, but capacity for social connection, capacity to interact with other people. Also for primary care, this is core business. GPs are seeing more people for chronic pain than ever before, and the patient encounters have really skyrocketed over the last 10 years. We also know that people with chronic pain are about 3 times as likely to be dispensed opioids or other analgesics as those without pain. So that's common sense, clearly. And these figures really highlight the burden of kind of opioid analgesics in this group. And this is in the context, I suppose, of medical practitioners across the country and internationally becoming cognizant of the fact that opioids in the long run confer a significant amount of harm and very limited evidence for benefit in most people with chronic pain disorders. So we're in this space where there's quite a push for people to come off opioid analgesics where that's possible or where we can reduce harm. But in the other hand, we also have limitations in what we can offer to people to be able to manage pain, to be able to manage the mental health and social effects of pain. So for us at Turning Point, running that chronic pain clinic, what we would often see is older adults from sometimes in rural and regional settings too, who present with pain disorders, and we're aware of making recommendations about the medication treatments, suggesting, for instance, that that be tapered or reduced, suggest that people are engaging in sort of psychological treatments and adjuvant kind of other treatments, physiotherapy, etc. For pain, but also really recognizing that there were limitations in terms of the resourcing of what people could access, both financial resourcing or just the availability too of some of these resources in their communities. And knowing that a lot of people were presenting with depression and anxiety symptoms related to their pain, and often because they were quite isolated. So I guess reflecting on that, what we were thinking about is how can we intervene for these kind of underpinning factors that underpin both the pain disorder as well as the dependence on opioid analgesics and a whole range of kind of mental health burden that kind of came along with that. So that drove us to think about delivering this project. And if we think about loneliness in general, there's been an explosion really of research in this area in the last 10 years, increasing recognition that loneliness as itself can be a construct that underpins a whole range of morbidity and mortality too. So 1 in 3 older Australians report feeling lonely, and loneliness increases the risk of death, any cause mortality by up to 26%. So that's quite substantial. It's in the same order of risk as obesity. And so if we think about this as a modifiable sort of risk factor for a whole range of illnesses and problems, then that's something that we can actually intervene on. The impact, for instance, on social connection on risk reduction, especially in older adults and retirees, is comparable to physical exercise. So you think about all the times, health professionals in general make recommendations about being more active or getting out and about. This is a substantial comparison too. So meaningful social connection, a whole range of literature for people who have pain has been shown to improve quality of life, perception of pain, mood and anxiety, and also clearly improving function. And that functional outcome is what we're often really interested in improving when people present with chronic pain. But the barriers to addressing these loneliness factors are really common. They're common across the whole range of the population, but they're particularly common in people who have chronic pain disorders. Because of that mobility factor that I talked about, and also for a whole range of different morbidities and mortalities can come along with that. So for instance, there might be factors related to the individual themselves, experiences of anxiety or depression, the experience of pain itself, and anxieties around the pain impacting on capacity, fears and about that, and fears about the pain. Cost as well can be a significant barrier for a lot of people. For instance, suggesting that people join a community group or engage in activities that comes along with a membership or subscription cost can itself present a significant barrier. And then people developing sort of confidence or motivation or capacity to be able to act on these recommendations by themselves without support. At a clinician perspective, so if we think about primary care settings or health professionals working across a whole range of settings, including alcohol and drug settings, there might be limited time, first of all, in some of these consultations to explore isolation and loneliness in depth. Also, capacity and confidence of prescribers and providers to be able to think about this space. I think for many GPs, they would consider this core business and have a conversation with people. But on the other hand, there might be lots of other health professionals that don't necessarily feel they've got the skill set or the understanding of what's available in the community to link people into how to actually intervene with that experience of loneliness as well. So that led us to think about the social prescribing model. And for people who are in Queensland, you might be aware of a whole range of different social prescribing pilots that have really led the way in Australia. I think the pioneering project's been led by teams like Wellways and other teams in Queensland. We were lucky to be able to present some of this data in correlation with Genevieve Dingle, who's at UQ, and she has led a whole range of literature as well in this area. So I think with social prescribing, what we're drawing on here is decades of literature now that's started off in the UK primarily, looking at models where we were engaging health professionals, often GPs, as that being that first protocol, in a model where we actually link people into community resources. And that might be community groups, it might be social connections within their kind of local area. And the real key part of that social prescribing model is that link into a link worker. So So the function of having a person whose sole role it was really was to engage individuals in this community connection. And the idea that this social prescribing model is about a non-clinical or third sector model. So we're intervening here or seeking to intervene in clinical constructs. We're seeking to actually change experiences of pain or change experiences of depression or anxiety to clinical disorders. But we're also looking at how we can do that by linkage into these community groups or these this third sector sort of resource. And so if people are interested in reading more about this, the Medical Journal of Australia has done a whole range of different articles on this, including a Perspective and Insight article in February a couple of years ago. So I refer people off to read up about that. So thinking about older adults in general, and this slide's not super clear, so I'll just read out from my own slides. But if you're interested, I'd really recommend kind of looking at this article by Hamilton West and colleagues in 2020. And for older adults, social prescribing is a model that has a lot of attractions and benefits. First of all, older adults are often facing specific barriers in being able to engage in community groups. There might be, for instance, factors related to mobility specifically, particularly in the group we're talking about, who live with chronic pain. But also there are a whole range of different types of problems that people might be facing in older adulthood. That means that this is actually going to intervene on a whole range of problems rather than one specific activity by itself. So, I think we've known for a while that social prescribing could be potentially quite useful. The RSCGP has led a whole range of work looking at how this could be translated to the Australian healthcare setting. And there was a roundtable a couple of years ago. And this looked specifically at how we could translate this, but also what the barriers were in an Australian treatment environment. And so in terms of how we could make that happen, I think the majority of people said that they'd be really interested in terms of attending a community program or service if their doctor recommended that. But 75% of them would also say that they would attend an appointment with that link worker, the community support worker. And 58% said that the kinds of activities that they could attend were available. So they had some knowledge of that existing in the area. But the barriers really were around cost in terms of being able to access that service itself or that group. The timing, for instance, of what was available, transport and distance concerns. And then for a lot of people, this idea of not feeling comfortable and not feeling prepared, not knowing what to expect. And that's a function that's clearly also higher, that anxiety in people who might have chronic pain or might have depression or anxiety symptoms themselves. And also for people who have caring responsibilities, so that might be other family members, their spouse or their partner, for instance, as well as kids. So I think these were all kind of fundamental barriers that meant it was going to be challenging without being able to address these factors. So our project specifically aimed to address many of these barriers, but also we wanted to tailor an intervention that potentially could intervene on isolation and loneliness, but then have subsequent effects on pain primarily and experiences of pain in the older adult group. And we also wanted to see if there was any changes in sort of medication use or reliance on medication as well. So just by way of kind of an overview of the project that we're running, this project looked at sort of about a 2 to 3 month intervention phase. And that project involved quite an extended sort of assessment and social mapping framework. This assessment was done over the phone or on Zoom with the participant, and then formulation and feedback back to that individual, linkage into supports, and then an evaluation. So the evaluation framework was embedded throughout. Now, I want to draw everyone's attention to the fact that what we were actually doing here was entirely remote in this case. So we conceived this project pre-COVID, and we had a whole range of plans that were kind of really engaged in the community in the local area. And for us, that was in the Yarra Ranges Shire, which is regional essentially. So it's just outside of our catchment in Eastern Health. And it's an area where there are lots of community resources and supports, but it is about an hour drive into sort of metropolitan Melbourne. And we wanted to be able to access and support older adults living in that region. Then COVID happened, and this was early 2020 or so, and we started thinking about how we were fundamentally going to be able to intervene without being able to necessarily see people face to face, and also the types of social connections we were aiming to engage people with were often just offline. So there were actually, we'd see lots of community groups kind of shut down, not be able to see people face to face, and there were a few groups that were actually moving online. So sort of around August-ish of last year, August 2020. And if you're from Victoria, you'll know that we had lockdowns for much of last year and about a 3-month extended period of that. It was during that extended lockdown, I think it was 2.0. And in that lockdown, we actually really thought about the need for us to be able to pivot this intervention into an online space. And so if you take a step back and think about that, and this is an intervention for older adults, so groups from 65 and above, 65 to 85 was our target demographic. And we were working really closely with Centre for the Aging, COSHA, which is the peak body for older adults in Victoria and in Australia as well. And so speaking to our partners at CODA, we had a steering committee that we sought advice from, and really the fundamental advice was that that was going to be really challenging, getting older adults online, getting them interested in kind of doing things online, that the digital divide, the capacity of people being able to engage online was going to be a barrier. As COVID sort of dragged on, we started to think that that may be the case, that was a barrier we're going to address, but that this was a space that would give us really interesting and useful information. To our knowledge, the social prescribing space has entirely been looked at in face-to-face connections rather than online connections. And we wanted to see whether we could actually engage older adults in activities online. And if we did, whether that would have any benefits for mental health, for pain, as you would expect from a face-to-face connection. So this whole project kind of ended up going online and remotely delivered sort of late last year. And we continue to deliver it online. So I wanted to keep that in mind as we move through the rest of the slides to start to think about how that might impact on what people were saying. So that included provision of the device itself, a tablet device that we created out to people. And then we had an extended phase of tech support, essentially, from our team. So our team got technologically capable ourselves. And we also then linked participants into tech support options in their region. But we had a friendly voice, someone that they could keep coming back to with any questions really about how to use the device. We had a lot of screen sharing of Zoom calls where we'd actually be able to screen share and show people how to click on things that were relevant, etc. So quite an intensive sort of phase of that. So moving through what the key kind of key components were of our intervention. Those key components were aimed at addressing barriers to social prescribing in general. And so one part of it was quite a comprehensive assessment that we developed that mapped out people's social networks. So we wanted to understand who was in this person's life. So that might include people who they lived with or family members that they might have seen regularly, including, for instance, in lockdown, had phone calls with or on Zoom calls regularly. But also then looking at what else was in their milieu, in their context. For instance, would they go down the street normally and see people at the cafe, or do they have groups of people that they might meet with regularly? Were there also kind of more formal groups that they were attending? Were there hobbies and interests and that they were engaging with, and also that they sought to engage with? So in this process of developing that network and asset map, we also understood what they aimed to develop as well, and this was very individualized. So we, over a couple of sessions, got to know the person, essentially, got to understand what it was that they perhaps used to engage in and what they wanted to do again and why it was that they weren't doing that. And so, you know, this sort of work was presented in a visual way as well, with an asset map that we sent back to people so that they could have a look to at what that looked like at baseline for them and how this might change over the course of the intervention. Then I mentioned that we had a link worker function, and that link worker function was on the Zoom or on the phone. And we also developed a resource directory, which I'll take you through. And so, as I mentioned, when we moved online, one of the key things that we wanted to be able to overcome and circumnavigate was these digital divide barriers around actually just connectivity. I think if you live really in almost any part of Australia, you'll know that our reception in many parts can be very patchy. And in the Yarra Ranges in particular, this was a fundamental problem. We had to brainstorm different sort of providers and internet providers to be able to find an option that worked for most people. Also, we wanted to understand, would this online connection actually make any difference? Because all of the social prescribing literature really focused on getting people up and about in their community. And so could we still, you know, give people benefits if they weren't leaving their homes? And, you know, essentially what that led down to was that question, if we don't do this now, then when? And really thinking we need to kind of explore this space. So in the next few slides, I'm going to take you through some of the key learnings and results that we got from the intervention, and also take you through some of the outputs and resources that we developed. As I go through them, just be aware that these resources will also be coming up on the Turning Point website in a couple next week. So if people are interested in getting copies of that, just feel free to have a look at the Turning Point website in a couple of weeks' time. So these key outputs looked at a range of things. We wanted after the project to also have a whole range of resources in the community that people could continue to draw on. And in our intervention, we reached a small number of people in this pilot, but we wanted the rangers to be able to take this work on and still run with it following the intervention. And so what we ended up developing was quite a comprehensive resource directory of what was available face-to-face and then what was also available online. And our team sort of looked at online resources that were very specific to older adults in particular, and also specific to older adults who might be living with chronic pain. I've just got one example of one of these cards that we developed, and following feedback from all our stakeholders in our steering committee, we really realized that, a face-to-face sort of option was something we still wanted to develop, but if we were looking at online connections, storing all of this online was probably still going to be problematic for older adults. And I think what we ended up with was a range of postcards that we, first of all, sent out to our participants, but also have distributed kind of within the community so people can kind of pick these up. And they've got QR codes. So I think if you're joining us from probably anywhere in Australia now, you'd be really familiar with QR codes. And I think this is a possibility that might not have existed pre-COVID. So in terms of the activities, we had a range of postcards. All of them are two-sided. And one of them, for instance, this one's an example of the online activities one. And we kind of curated a range of things that were running. We also had connections with the facilitators of these groups, follow that up and made sure sort of the currency of these resources was being maintained, that these were groups that had run for a while and were going to continue to run, that people could actually continue to access them. This is just giving you a sense of what the back end of the resource directory looked like. So we had a whole range of different types of resources that we were trying to connect people to in a different range of categories. And this was really to be able to kind of scope a range of interest for older adults. Because I think what we were also hearing a lot from our participants and from our partner stakeholders was that older adults were often quite frustrated that they were sort of put into a group where they would be stereotyped or sent off to activities that there was an assumption that they would enjoy, for instance, a knitting group or a gardening class, for instance. But then there was a whole range of other things that they might have interest in that weren't being tapped into. And so we made sure we had a really broad range of different connections and activities that people could kind of look at in amongst our resource directory. So as I was saying, this is the back end, and what we've ended up doing with this resource directory is actually speaking to a number of different providers in the region to actually get this resource directory embedded into existing council websites and council pages that are searchable and actually then link people directly in. This is an example of the different kind of postcards that we developed, and we looked at sort of Facebook groups, community-based groups, online activities, the one I showed you, and tech support. So the tech support one is quite specific for people who might already, for instance, have a computer or a tablet device in their home already, but just were wanting to develop sort of confidence and skills to be able to use that, to be able to access Zoom, for instance, or access Facebook groups through that device. And so there's a whole range of different supports there as well. The Facebook groups were specific to older adults who might have experiences with pain. So they include pain support Facebook groups, and all of the groups that we sort of curated, we also had connections with those Facebook group providers so that we knew that there was a safe and kind of comfortable space for people to connect with, and that many of these forums were also sort of moderated. And then the third resource that we developed was a complementary resource workbook. I'll just give you a bit of a snapshot here on the next page of what that looks like. Again, this will be freely available on the Turning Point website in a couple of weeks. So if people are interested in accessing this, it's just a download from there. We put together all of the postcards that I showed you, as well as newly developed resources that focused on pain and social connection specifically, and put this together in a workbook that we've now sort of mailed out to participants and general practices in the region. And this resource workbook had a range of different targeted worksheets. What we did was in the first page, look at different activities that people could do, and they're all sort of self-guided type activities that people can do by themselves. And then on the back side, we also have specific areas where people can take guided activities and put their own responses, for instance, develop kind of management plans for themselves, around sort of relaxation or flare-up management, and also cues so that people could take this into a health professional, for instance, their physio or psychologist or their general practitioner, to be able to discuss some of the things that were coming up for them and integrate that better into their kind of holistic management overall. So sleep, relaxation, loneliness, and flare-ups were the four sort of key topics that were kind of discussed with participants being the kind of key components of managing chronic pain. So just moving on to results, and just encouraging if anyone has any questions, just pop that in the chat and we'll take that at the end. But just moving through the results of our intervention, as I mentioned, we had a few pivots along the way, and that kind of impacted on our capacity to deliver a large intervention. So we actually scaled back a lot of the intervention itself because of the COVID context and because we were actually sending tablet devices out to people, so that limited our budget somewhat. But in the end, what we aimed to do was get 10 people in and see if it made any difference for 10 people. What we ended up doing, I think, was recruiting sort of about 14 or 15 and then looking at the pre and post measures in the 10 who completed. As I mentioned, we had 14 older adults enroll in the intervention. And in terms of the recruitment method, I mentioned at the start, looking at primary care as being the main portal. We started off with that based on kind of existing literature. And what we actually ended up doing was going straight to the person rather than going through their primary care provider, because I think we faced lots of barriers in terms of engaging primary care providers into the intervention. Not because for lack of interest. I think many of the GPs we spoke to in the primary care practices were really keen and passionate about social prescribing as well. I think what we find when we translate this into the Australian space is that we don't necessarily have kind of the infrastructure, the framework in which to be able to do this work easily. And I think it means that people have to be quite creative about how they look at sort of billing items or, you know, creating the time and capacity to be able to undertake some of this work. And so what we ended up doing was being able to just run a Facebook ad campaign and also be able to engage kind of local providers of community groups to basically spread word of mouth and get lots of people in that way instead. And so what we ended up doing was getting 9 participants who completed both the start and the end, and mostly men in that group. And they completed both the baseline and post-program measures. And the average age was around 73, so smack in the middle of that. What was really interesting for us was that 78% of the people we recruited were living with someone else, or living with their spouse or partner, and only 22% lived alone. So that kind of challenges the assumption too that loneliness is experienced by people who are living alone by themselves. And I think what we're increasingly finding is that, you know, these experiences of isolation or loneliness can exist regardless of who is around you necessarily. It's about that experience of sort of connection to and belonging as well. And 93% of the group were retired. And on average, this group had really been living with pain for a long time, for over 26 years, and on average had been taking medication for 16 years. So people had been kind of living with this experience for quite a while, and I think this made us also reassured that the results that we were getting in this group were probably not dissimilar to, for instance, the average person who might come into a clinical service or a general practice in terms of that burden of pain. In terms of loneliness, the majority of our participants at the start of the intervention was scoring at risk for social isolation. And in fact, 1/3 of those participants were scoring in the moderate range and 44% in the very severe range in our scale. So that was quite significant at the start. And just keep in mind too, this was probably around the back of our second lockdown in Victoria. So people had probably had experiences of maybe 2-ish months plus of having lockdown at that point. And we're really kind of reporting moderate to very severe loneliness at that point. Post-program, only 11% scored in the very severe range. And if people are interested as well, for the majority of our participants, there continued to be a couple more lockdown periods in that phase. We can't control for all of the lockdown impacts on loneliness, but I think overall there were experiences of lockdown throughout the intervention for most people. And so what we saw was really that people were shifting from that very severe end of the range into lower scores basically over the course of the program. What we also saw promisingly was that there were changes in sort of pain experiences over that time. And people were asked to report both their average pain as well as the current pain at the time of the interview. And so we see that kind of coming down. 78% reported a decrease in their average self-reported pain, and 56% reported a decrease in the current pain at the time of the interview. So that's quite substantial for an intervention that sort of was quite low barrier, not particularly intensive, delivered remotely, and for most participants lasted for about 2 to 3 months, so not very long. And so that was really reassuring for us to be able to see that. And in terms of depression, anxiety, and stress, we used the DAS-21 to measure this and did that at the start and the end. And overall saw really promising reductions across the time of the intervention. Stress levels didn't significantly decrease, but yet we still saw sort of depressive and anxiety symptoms come down. 44% reduced depression symptom severity and 67 anxiety severity. So in summary, just putting all of that together, and we've got lots more data around sort of the measures we used. So people are actually interested in sort of the back end of that methodology, feel free to contact us, and we're happy to share more details. But essentially what we were seeing is these really promising reductions in the core constructs we were trying to change, being pain, but also that we're also seeing changes in depression and anxiety scores. So we knew that this was actually going to intervene in a whole range of different things for people. And overall, people reported quite high satisfaction levels. I mentioned at the start that we were also wanting to see whether opioid use in particular and medication use decreased. In the end, because we didn't get a lot of the general practitioners kind of engaged in the intervention, we had lots of gaps in the medication summaries and being able to understand whether the total opioid use actually changed with the intervention. So we aren't really able to kind of comment on that. I think we had lots of anecdotal evidence, certainly from participants, that they felt less reliant on the medication. But I think that we still need to do kind of more research in this area in a bigger sample to be able to understand if medication use specifically would come down. In terms of some of the qualitative data, just wanted to share some of the quotes from some of our participants. Really kind of opens up, I think some of our minds on what we can change when people feel more connected. And just take you through that. You'll have the slides too if you want to read it in a bit more detail. But I think that idea too around connection, also sort of bringing value and meaning to people's lives was really lovely to hear, that people felt that their opinions were worth hearing, that people were actually relying on them, and in a way that perhaps they hadn't felt valued or heard for quite some time post-retirement, and in a space where they had very limited connections otherwise. And for many people, they kind of knew what was out in the community. They knew that there were things that they could tap into, but just that little push of trying to be able to do it, their comfortableness with being able to join something new and that anxiety about that newness, that was something that the team could help them navigate. And I think that made a huge difference for a lot of people. I think in terms of pain levels, this was something that came out from a lot of participants. Again, we saw the sort of reported pain scores come down, but people were also saying that, they weren't sure of necessarily their pain disorder, whatever condition was driving their pain, whether that had decreased or changed necessarily, but their tolerance had gone up. And certainly, their tolerance of being able to do other things and take their mind off the pain too had actually improved as well, which was really great to hear. So in terms of what we've done with the project, now we're right at the end of the project, and you're probably the first group to hear all our results hot off the press. And so I think we're really sharing a lot of these resources really widely now that the project is coming to an end. And we've had these resources that I shared with you before go out to the local councils and libraries, also to a range of pain support groups in the region, and a range of healthcare professionals and providers in the region. We're also sharing it. You guys are on this list of webinars, and we're also talking to sort of the Victorian Department of Health as part of that Royal Commission implementation to see whether any of this could be of use to the broader kind of mental health sector as well. I think there are lots of different constructs that this can help with, and these are promising results, but they're very small kind of pilot. And so I think what we'd really love to see is a larger sort of trial of this for older adults across Australia. And there are lots of good pilots kind of running across Australia now. I think this is really kind of gaining momentum. It's a really exciting space to be working in. So I really value being able to share that with you. I'm just going to move you to our last slide. And so again, if any questions, just pop them in the chat and we'll get to that in a second. The key learnings for us, I think, just taking a step back at the end of the intervention, it was really rewarding to see kind of benefits across pain, but then a whole range of other things too. And I think if we had a longer intervention and also more engagement with health services specifically, it'd be really fantastic to be able to look at a whole range of other potential impacts. So that includes, for instance, medication use, as I mentioned, but also sort of healthcare utilization and need, for instance, to present emergency or hospital departments, etc. be really interesting to see if it did have potentially any benefits in that regard. As I mentioned, we were looking at online connections in this space, so it was really interesting for us to see that those changes happened even though the majority of connections that people were developing were online. So, you know, for most of that time, people couldn't leave their homes regardless of whether they had pain or not. And so we were really able to kind of get people connected in a time when that was not available to them. It'd be interesting to see if, again, this ran outside of a COVID kind of environment or context, whether they would still translate. But I think with that online connection, it challenged a lot of assumptions that our team and our steering committee, et cetera, had about the capacity to get older adults online, and also the importance of kind of tech support in that process. So making sure that there was continuity in that tech support, that that was given to people rather than being requested. So people didn't have to kind of put their hand up and say, I'm not sure what to do here. We had regular kind of calls with people and help them kind of navigate a whole range of different things. And then I think the next key point for us was also looking at that link worker role. The link worker is a really central part of social prescribing models. And I think what we really want to emphasize is kind of clarifying that in future models that run, in order to really be able to rely on that individual's relationships with community providers, with stakeholders. The success of that linkage really relies on the robustness of that relationship and that person really knowing the groups that they're linking people to, understanding what's a good fit for that individual, understanding, you know, what barriers that person themselves might face, and making sure that people feel comfortable when they attend the group and the community supports. So that link worker role is really critical. But we also, you know, challenged that idea that it needed to necessarily be someone within that community who was based at the community health service, for instance. So many existing kind of models really rely on many link workers across a whole range of kind of community health services. And that can be a cost limiting factor because it relies on that health service to be able to salary support and an individual in that sort of role. I think it's a really valuable role. And I think for, you know, areas that can do that, I think that's really important. But then there might also be lots of communities that can't actually finance a link worker function in their region. And I think starting to think about where that can be delivered remotely really kind of opens up kind of options for many communities. And then I think the last part is that point I mentioned before around kind of general practice and primary care, and just thinking about how we can embed this in a more fulsome fashion in a way that is in the workflow for a general practitioner and is billable and is a realistic kind of expectation as well for both the provider and the patient too. For many of our patients, they hadn't discussed kind of social connection or isolation with their doctors at all. And so I think this gave them an opportunity to kind of bring that into the health space as well and mean it's part of the, you know, the part of the expected interaction with the professional. So I think in future models, that's still something we need to test. We had a number of GPs on our own committee who kind of supported the linkage, and we worked quite closely with our primary health network too in embedding that. But I think the next tranche will be really kind of testing newer models of how that will work better. So I might leave it there and open up to some of the questions in the chat function here. And I'll just leave the slide up, Tracy, and throw over to you.
Yeah, thank you, Shalini. That was wonderful. We do have a few questions. The first one was, with the benefits to social connection for our mental health and now evidence for pain reduction, do you think there is a need for more social community support groups to be directly resourced or funded by health providers? If so, what sort of group services would you like to see expanded or developed?
Yeah, that's a really good question because it kind of takes us through, you know, if we've kind of done this little bit of the spectrum of evidence creation, what's the next step? I think reflecting on the international space here, so both in the UK, Canada, and I think New Zealand have a bit further along than we are here in Australia. And I think there's a more sophisticated kind of framework around social prescribing, which both supports it in the primary care sector as well as looking at what's in the community. And there I'm aware there's, you know, for instance, grant funding and kind of stipend funding that community support groups of a variety of types of support groups can access to be able to enhance their sustainability. I think in Australia, I still think there's probably a need to look at the types of support groups, like was mentioned, not just support groups, but a whole range of social kind of connection opportunities to be able to kind of finesse that. I don't think we're quite there yet in terms of the evidence. And I think that pathway between, for instance, do you need to go to see your GP in order to be able to link in with the group? or in order to be able to link in with a link worker. Other models that are currently being piloted don't necessarily rely on a health professional referral. They rely on just the base of having a link worker in a team. And so people can go directly to that link worker if they want to. The risk there, and these are what's being tested in the models that are currently being piloted, the risk there is that it relies on the onus and the individual to be able to make that connection to the link worker themselves, so that people who might be more anxious or who might not necessarily self-identify having problems with loneliness or isolation, they might not be able to take that step, and that they might lose out. So I think that's probably where the evidence needs to be sort of created in Australia first. But I think alongside that, in parallel, I think there's substantial evidence across certainly chronic pain, mental health, but also for drug and alcohol. We know in core ARD work that social connection is critical, especially during that recovery period where people might have done a detox, etc., and working on ARD counseling. But it is going to be that social connection that helps people kind of move on. And creating that social connection, that's where these supports in the community are so vital.
Yeah. So that sort of leads into the next question we have, and that given that social connection is seen as a necessary component in that recovery from substance use issues, and given that we have so many sort of younger people in our OTP programs and in sort of our AOD centres generally, do you see this program being able to be adjusted and implemented for other age and social groups, maybe link workers in AOD centres, that sort of thing?
Definitely, absolutely. I think the natural kind of corollary is to be staffed with older adults, and I think a lot of the evidence has been started in older adults like ours. But I think, certainly working in drug and alcohol, we know that social connection is a core construct for people across the lifespan who have the challenges, and that's similar as well as in mental health. And I think there's increasing understanding that this is going to be relevant and useful for people regardless of their age. Obviously, the types of social groups we'll be connecting to need to be nuanced and appropriate for across the lifespan. But I think this is going to grow across different kind of sectors of the community.
Excellent. So is the study an intervention to curb mature adults from using opioid analgesics to manage loneliness? So I guess, are they using the opioids for their loneliness because of those feelings of loneliness?
That's a really interesting question, because I think kind of comes down to experiences of pain and how we conceptualize pain, and how pain itself is so closely linked to, I guess, just general distress. That could be psychological distress, that could be depression or anxiety for some people. But I think for many people, certainly working in drug and alcohol, we know that lots of people who have opioid use problems, will freely self-identify as using opioids to manage distress of a variety of different ways. That might include distress that's connected to loneliness. It might be broader than that too. For many people, experiences of trauma might underpin a lot of this sort of self-medication trajectory that leads people to an opioid use disorder. For mature adults who are kind of living with opioid use disorder already from the analgesics, I think what we were kind of focused on was helping them get off or taper or reduce their reliance necessarily, and sort of understanding how loneliness and distress related to loneliness was impacting on that. But I think the other end of the spectrum is also really interesting in understanding how people might be using opioids to manage that in the first place too. And some people might be more vulnerable to that than others.
Yep, good. Was there much resistance from them? You were saying how the participants did pick up that technology with the support and everything. Was there much resistance in the beginning to even sort of look at that? For older people, often the thought of learning something new or going into an area they're not sure of. Yeah, was there much resistance there to start with?
Do you know, there was actually quite a lot of resistance from our own sort of steering committee, our group, our team kind of thinking about this to start with. There was quite a lot of resistance probably for a few months as code was starting to pick up. I was thinking that, was this even going to be possible?
Yeah.
And I think I think the lockdown restriction did catalyze this. I think it broke down some of those barriers for older adults, because there was suddenly a space where there were so few other options, and the idea that, if I could have this opportunity to learn this, then this is the time to do it. And so I think that was part of it. But I think also there was definitely some resistance to kind of, what am I going to do with this tablet when it arrives? We thought about that really carefully, and sort of, we had a number of contact calls before we sent tablet devices out as well, to make sure people kind of prepared for what to expect, had really kind of step-by-step guides and what to do when they got it, etc. So we kind of probably overcompensated. We put probably lots of detail in terms of how to manage that. But also for some people, we had a couple of at least older adults in our group who had tablet devices as well, were comfortable doing certain things on it, but not other things. And so it was kind of just breaking down what are the barriers you're individually finding? Is it, for some people it's a reception issue, or, or they'd heard about Zoom but didn't know how to download it or do anything else with it. So it was kind of, breaking down those steps in a very individualized fashion with people.
Yeah. Oh, good. Did you notice a reduction in the prescription of opioid medication for pain management? And also, was there an increase in other medication prescribing sort of replacing, or was the social interaction able to reduce that on its own?
I might answer the second part of that question first. Yeah, so we didn't see increases in medication, like for instance, benzodiazepines or antidepressants or anything like that. We didn't actually see increases overall in medication, and keeping in mind it's a fairly short intervention too. So in that period of time, we didn't see any changes. I guess in terms of reduction in opioids, which was the main thing we were hoping to be able to measure, there were a few participants that had more comprehensive summaries, and they had less reliance on sort of that as required medications, PRN type medication, which they kind of self-monitor and manage themselves, and that sort of came down a little bit. But I still think we need probably a longer intervention and more robust kind of integration to be able to actually look at that in a fulsome way.